and welcome to Economic Solutions. I'm Leonard Zane, and I am joined here once again after 4 years by Professor Gerald Kominski of UCLA, with the subject now being the Affordable Care Act. Jerry, welcome back to the show.
Thanks, Zane.
I'm going to give a little information to our audience about you and your background. We gave a lot years ago, but Gerald Kominski, PhD, is a professor of health policy and management and director of the UCLA Center for Health Policy Research. He also currently serves as an associate director of the California Medicaid Research Institute, CAMRI, and represents UCLA in his multi-campus collaborative effort. His research interests focus on evaluating the costs and cost-effectiveness of healthcare programs and technologies, with a special emphasis on public insurance programs. So Jerry, here we are 4 years later. Back in 2009, we were talking about the case for healthcare reform. And we had you live in the studio. Today we have you by electronic communication. And at that time, you were presenting all kinds of charts and graphs on the advantage of healthcare reform. And now we finally have the Affordable Care Act, sometimes called Obamacare. And to hear the president himself talk about it, he appends it a little bit to Obamacares. But given the Affordable Care Act, exactly for our audience, Jerry, what is the Affordable Care Act? What does it cover?
So, Zane, the Affordable Care Act, first of all, it's a very complex piece of legislation. There are a lot of components, but let me just focus on the major pieces and what the law is really at its heart trying to do. This is a piece of legislation that is attempting to address the large portion of Americans who remain uninsured in this country. So as of today, there are roughly 48 million Americans without health insurance. In California, our estimates are on any given day, 5.8 million Californians who are without health insurance. So the Affordable Care Act is saying, look, there are a number of programs. There's the Medicare program for the elderly and disabled. There is Medicaid that covers many poor families and children, but not everybody who's poor. There's employment-based insurance, which is where the majority of Americans get their health insurance. What we want to do is find a way to either expand coverage in those programs or provide subsidies to people who can't afford insurance today to purchase insurance in the private marketplace. So the law is really targeted at the currently uninsured and finding a way to get them insured, as well as providing relief to the millions of Americans and roughly 2 million Californians who currently buy insurance on their own, completely out of pocket because they do not have an employer providing insurance to them at their place of work.
So Jerry, what are some of the key or the highlights of the Affordable Care Act then for these people?
So the law provides benefits to many people who fall below a certain income level, and that income level is 400% of the federal poverty level. And just to put that in sort of more concrete terms, because most people don't know where their income stands relative to the federal poverty level. For a single individual, 400% of federal poverty is roughly $46,000 a year. For a family of four, 400% of the federal poverty level is approximately $94,000 a year. So if you use those thresholds and sort of look at gradations between if your family size is different, anybody below that threshold may qualify. So for anyone between 139% and 400% of the federal poverty level, those families and individuals can qualify for subsidies from the federal government through the exchange located in their state. And in California, our exchange is called Covered California. So individuals and families can go on to the exchange and apply for a subsidy to purchase private health insurance that's going to be sold in the marketplace. And Covered California opened 2 weeks ago on October 1st for business, and they are currently enrolling individuals for coverage that will begin in January. So anyone below 139% of poverty will be eligible for expanded Medicaid starting in January.
All right, now, Jerry, my understanding is that we have a website in California called Covered, COVERED, CA.com, where people can make inquiries, right, on, first of all, looking for various insurance companies, apparently, that provide various rates and quotes, and secondly, to investigate subsidies if we happen to be in the poverty level. Is that right?
Correct. Covered California is our exchange in California. Their website, as you said, coveredca.com, is the place where people go to shop for these new insurance products and to apply for subsidies to purchase those products.
Now, California could have standardized on the federal plan, apparently, for an exchange, or the federal exchange plan, but California opted for its own exchange. Is that right? And maybe you, if that's right, maybe you can explain what the difference is between the federal exchange program and the California state exchange program.
There was a provision in the law that said if a state does not establish its exchange in a timely manner, the federal government by default will set up the exchange. Well, the default option has been employed by 36 states at this point. Some decided not to establish their own exchange simply because of the timetable and the fact that it was easier to default to the federal option. California was the first state to move forward with legislation to create its own state-based exchange. That law was signed by former Governor Schwarzenegger, and we have been working in California for over 2.5 years to get our exchange up and running.
So, Jerry, can you explain what is an exchange? What does it shop for? What is the purpose? And how does it work?
So an exchange is just another word for a marketplace. I would say that for most Californians and most Americans, the exchange is the same principle that many people experience on an annual basis during what's known as open enrollment season. For most people who get their health insurance through their place of employment, if in fact their employer offers multiple health insurance options, people experience going through an open enrollment period where they can either sign up for the first time for insurance or change their insurance, but they can shop among the options that their employer is offering them. For anyone in California who is a municipal or public employee and gets their insurance through CalPERS, CalPERS is an exchange. For any federal employee who gets health insurance through their federal job, they have been shopping on an exchange called the Federal Employees Health Benefit Plan for decades. In fact, the Federal Employees Health Benefits Plan is, in a sense, the template for all insurance exchanges. It's a marketplace where someone on behalf of a large population is negotiating with insurance companies to offer insurance policies to a group of employees or a group of individuals.
The Kaiser Family Foundation has calculated that about half the people who currently buy insurance on their own today will be eligible for subsidies from the government. That would be those with incomes 4 times the poverty line, as you said, $46,000 for individuals or $94,000 for a family of 4. These subsidies are projected to be worth an average of $5,548 per household, which would effectively discount the projected price of insurance by 2/3 on the average. And so both National Public Radio and the Kaiser Family Foundation collaborated to produce an online calculator for people to estimate their premiums and subsidy amount based on where they live, income, and family size. Now, is there also a calculator at the coveredca.com website?
Absolutely, there is. And I would actually encourage Californians to use the one that's here in California. The Kaiser Family Foundation website has a good calculator, but the one at coveredca.com has the up-to-date information regarding the actual price of products that are being sold next year in California's exchange. And so I highly recommend that people go to that website instead of the Kaiser Family Foundation website.
Okay, I actually went to the Kaiser Foundation website and I plugged in somebody with a $30,000 gross income, and I ended up with a subsidy of around $450. But again, it would be better to use the coveredca.com website, and that would be up to date.
Exactly. What you want to do is you want to shop for products that are going to be sold in California, and the precise cost of those premiums that are available to you in California in your market area, because the premiums depend on where you live in the state. So the same bronze plan offered by, let's just say, Kaiser in Los Angeles will not cost the same as that bronze plan in the Bay Area. So, and the Kaiser Family Foundation website is not necessarily going to provide you with the precise details of California's market. Covered California, coveredca.com, will have the latest information about the prices and the market in which you live and what is available today in California.
Now, Jerry, you mentioned the bronze tier of health care coverage. The law establishes 4 tiers of coverage: bronze, silver, gold, and platinum. All categories offer the same set of essential health benefits. What the categories specify is the division of premiums and out-of-pocket costs. Bronze plans are those that will have the lowest monthly premiums and higher out-of-pocket costs, and vice versa for things like platinum plans. Can you explain roughly what these 4 possibilities are?
The 4 metal tiers all do, as you correctly said, they all have the same essential health benefits. So there's no difference whatsoever in the underlying benefits that are covered. The only difference between a bronze plan and a platinum plan is that the bronze plan has a high deductible. And just to remind your audience, the deductible is the amount that you have to spend out of pocket before your insurance pays anything. So the bronze plans that are being sold next year in California in the exchange will have $5,000 deductibles. That means you have got to incur $5,000 of out-of-pocket medical expense before the insurance pays a single dollar. After you've exceeded that limit, you will then have co-payments for all services except for preventive services. Preventive services are the only services that are provided for free and are not subject to the deductible. But all other services are subject to the deductible and have co-payments when you actually use them. The platinum plan, in contrast, will be a higher monthly premium, but it has no deductible. So the first time you go to the doctor, the first prescription that you fill, you will have insurance coverage immediately and will pay a smaller copayment at the time that you use that service compared to somebody with a bronze plan. For example, for an office visit, you'll pay $20. someone with a bronze plan would pay $60 for that office visit. You both have coverage for the office visit, but the platinum plan is, think of it as paying more upfront, less when you use it. So they're gradations. So bronze, lowest premiums, highest out of pocket. Platinum, highest premium, lowest out of pocket. Silver, a little bit closer to the bronze, a little bit higher monthly premium. Gold, even higher monthly premium. So these are just gradations. Think of this as variations on a theme, but the underlying benefits are the same in all four tiers.
Now, 4 years ago when you were on the program, you presented a chart that showed, I believe, 9 countries, and it compared the cost per person of health care coverage. And the United States was, on the average, double of all the rest of them. Is the Affordable Care Plan going to make the United States look any better, worse, the same in comparison to the other countries?
So I know there's been a lot of rhetoric about whether or not the Affordable Care Act is going to bend the cost curve, is the term of art that people have used. And I think that there are differences of opinion. In my opinion, the Affordable Care Act is not about controlling the cost of healthcare spending. The Affordable Care Act is about filling in the gaps and trying to significantly reduce the number of uninsured Americans. Now that will, in the short term, increase some cost because we know that being uninsured is a very effective way of controlling healthcare spending. And it's just a fact. And it's just like premature death is a good way to control spending as well. These are not desirable outcomes or goals for a civilized society, but it is a fact that if we don't survive as long, we spend less. And if we're not insured, we spend less on healthcare. So this is about trying to improve the equity of the U.S. healthcare system. What I would expect to see is that healthcare spending in the United States is going to continue to increase faster than any other Western nation. And I would expect to see that in the longer term, over the next 5 to 10 years, that some of the really poor health measures in the United States will start to improve because we'll have fewer people going without health insurance. So I don't think that we'll see shorter term or even longer term reductions in our spending, but we're likely to see significant increases in some of the health indicators where we lag severely behind many countries throughout the world.
Okay, Jerry, I looked at a number of countries that have national health care coverage. As you mentioned in our show 4 years ago, it was Prussia that actually had the very first national health care coverage in the world, and that went over into Germany now, which is a major country in national health care. And I looked at Germany and I looked at Canada, which seem to have goals similar to what we have in the United States, namely that they're both very high-tech societies. And so healthcare costs go up largely because of technology and prescription drugs, where these countries want to get the best there is. And so their costs go up. And so they're faced with, in controlling their costs, they're faced with saying, well, okay, we want to give a certain standard coverage to everybody. And then if people want to go beyond that, then they have to go the private route and get some very high-priced type of high technology approach. And so those two countries are saying, well, our experience is the biggest driver of rising healthcare costs is really technology. It's not anything other than that. And so we have to manage overall for our people just how much technology do we want to give people or be able to cover that we can afford, and therefore keep this whole system financially solvent. And so I'm wondering, in your view, what would it take, since these countries, France also, by the way, which has another country that has half the cost per person that we have, what would it take? It sounds like the Affordable Care Act is like a first step in a long journey to actually end up being equivalent to what other countries can do at much less cost. What, in your opinion, would it take for the United States to end up being more comparable, equivalent, and even competitive with these other countries?
Well, Zane, that's a fascinating question. And to quote Winston Churchill, Americans eventually do the right thing after they've exhausted all of the other options. We are in a historically long period of exhausting every other option about how to make healthcare financing for all Americans work. And we are fundamentally divided as a nation about whether we can get there by letting the market do it, or acknowledging that healthcare is not like other markets, that there are severe sources of monopoly power, distortions of the market, and market failures, and therefore regulating the market so that we don't get these distortions. Because we have not crossed or found a way of building a bridge across that divide, and you can see it right now. It's being fought in the politics over the Affordable Care Act. Our government is currently shut down because a group of politicians think that Obamacare is going to ruin America. That's their stated goal. So this is not just an extreme group, unfortunately. There's some public sentiment in support of this position. What I will say is that this is the most significant step towards reducing the number of uninsured in the United States in the 50 years since Medicare and Medicaid were enacted. If it takes us another 50 years, I will be personally very disappointed. But there is reason to believe that once we stop fighting over whether this is the law of the land or not, that the benefits of this law will far outweigh the negative consequences, far and above outweigh any negative consequences. And then we can move on to some of the other serious challenges we face, which is how do we afford to pay for such a large portion of our country's economy towards healthcare when other countries spend far less and get better health outcomes.
So we're going to display your updated chart of the country comparison of cost per person in the United States versus the other prominent nations. And the interesting thing about this is that the United States is the only advanced civilization left on the planet, right, that doesn't have national health care. Isn't that true?
We are the only major industrial nation without universal health care. It is a sad fact that we are reminded of every day as the political opposition and battles over even this what I consider to be very moderate approach to expanding health insurance to millions of Americans has generated intense opposition and intense political animosity.
Our costs remain double these other countries, these other of the 9 countries. Our costs remain double that, and yet data you showed in our previous program that we had in 2009, data showed that people in those countries actually live longer and healthier than we in America do, and yet they pay half what we pay.
Yes, for anybody who works in the public health field, these are well-established truths that the U.S. spends far more than any other nation and gets far less for its dollar. The question is, how do we reach a political consensus about correcting that and getting more value? And that continues to be a challenge in the United States because there is a fundamental divide about what the best approach is. Any attempt to increase the role of government triggers a strong conservative backlash, and even moderate approaches like the Affordable Care Act we've seen. And I will, quite frankly, I'm not sure that anyone could have predicted 4 years ago. It'd be interesting to go back and look at that program in my last appearance, whether anybody could have predicted the intensity and the longevity of this ongoing effort to reverse this law 4 years later, this very moderate approach to providing health insurance benefits to about 22 million Americans.
Well, Jerry, the Congressional Budget Office is nonpartisan, and they do projections all the time. And in 2011, the Congressional Budget Office, or CBO, projected a net deficit reduction, by the way, of the federal budget of more than $200 billion during the 2012 to 2021 period because of Affordable Health Care Act. It calculated the law would result in $604 billion in total outlays, offset by $813 billion in total receipts, resulting in a $210 billion net reduction in the federal deficit. So here is the nonpartisan Congressional Budget Office saying, you know what, this thing actually saves us money. What is your comment on that?
Well, I believe that the Congressional Budget Office's scoring of the net impact of the Affordable Care Act is, relatively accurate. Now, when I say relatively accurate, anybody who's an expert in the federal budgeting process, and specifically in the techniques that CBO uses to score the impact of legislation and laws on the federal budget, recognize that there are some peculiarities and there are ways of making programs look more or less attractive depending on how you present or how you structure the program. Having said that, that's true. That has been true for every piece of legislation that's been scored by CBO over the number of years. They are a nonpartisan group. They are the group that reports to Congress, and their scoring of the financial impacts of the ACA continue to show that it will have a net reduction in the deficit. So it does raise the question, why would a political party that seems dedicated to deficit reduction be so opposed to a social program that is fully financed and will, according to their own agency, will contribute to deficit reduction?
I want to respond to that once more. We've done this several times on Economic Solutions. We have ideological claims going on here, and one of the things that I'll again explain is what socialism is and what civic capitalism is. Socialism, and this goes back to Karl Marx, who defined it, who also defined capitalism. He defined capitalism as private ownership of property, and he defined socialism as community or governmental ownership of all means of production and property. So what we have with the Affordable Care Act is actually government channeling funding into the private sector for health care coverage and not government ownership. In fact, Medicare is not owned by the government. That's another one that channels resources to the private sector. Social Security is the same thing. It is not owned by the government. So those things are not socialism. They're called civic capitalism. What is socialism is the military that is owned by the government, the police, public libraries, public schools, and public schools were advocated by Thomas Jefferson, by the way. Those are all socialism. But when you channel resources by government into the private sector. That's civic capitalism, and it's done all the time. So ideologically, I think we need to straighten that one out. And I think we have a lot of people who just haven't gone to the dictionary to find out what these things are and find out the differences between them all. So another thing, by the way, that the Congressional Budget Office stated, Jerry, and I'm sure you probably know this, they also stated that the Affordable Care Act would, quote, substantially reduce the growth of Medicare's payment rates for most services. Wow, that surprised me. What is your comment on that?
One of the ways that the law is financed is by reducing the amount of money that will be paid out under the Medicare program over the next 10 years. Now, there are a couple sources of reductions. One is in what's known as the disproportionate share payments to hospitals under the Medicare program and the Medicaid program. These are subsidies that support hospitals that have a large percentage of uninsured patients. And the rationale for reducing those subsidies over the next 10 years is that if you're subsidizing people to buy insurance on the one hand, then you shouldn't have to subsidize hospitals for treating uninsured patients because they're going to be a lot fewer. But so that's a savings, and that's built into the assumptions, and that's savings to the Medicare program. There's other savings associated with reduced payments to providers, that they will grow more slowly, the payments to hospitals over the next decade. And then there are savings associated with reductions in the payments to Medicare managed care plans over the next decade. So, but these were not a result of the advantages of providing subsidies per se. In other words, it wasn't because we're now have fewer uninsured. These reductions and savings in Medicare were deliberately programmed into the legislation in order to reduce overall demands on government spending and to afford basically an opportunity to expand subsidies while saving money on the Medicare program. So these were political decisions that were made. These are not positive economic spillover effects per se, except for the disproportionate share. That's a direct economic benefit to the Medicare program. The others were deliberate policy decisions that were made to make this budget neutral.
So therefore, what you're describing, Jerry, is really a trade-off. They pulled something out of Medicare, but they put it into this plan.
That's correct.
I see. So it's not really an overall saving. It's just in a different pocket.
Well, I mean, it's a savings to one program. It means that the financial viability of the Medicare program has actually been improved as a result of the Affordable Care Act. We were facing possible shortfalls in the trust fund in 2017. That's now been pushed back another eight or 9 years. So, the Medicare program's financial stability, and if you look at this in the trustees report, was significantly improved once the ACA was enacted.
Now, to your knowledge, Jerry, were other countries consulted, who've been doing these things nationally for decades? Were they consulted by the United States when we drafted the provisions of the ACA?
Can you hear me laughing?
Absolutely.
So I know you're not joking. I know that was a serious question, but I'm laughing in response because after all, Zane, this is America. We don't need advice from anybody about how to do anything. We're world leaders. And but to answer your question seriously, no one consulted other governments about how to reform healthcare. I will tell you that in the academic community and in the policy community, that people do pay attention to what's going on in other countries and looking for the best practices. And I would say that one of the most interesting developments, in my opinion, in my field of study, which is broadly, health policy and health services research, that one of the most positive developments in the last decade or so is that there's a lot of interest in trying to find out what best practices are, regardless of where they originate. And there is always room for learning from somebody who's doing things better. Sometimes the market forces you to do it, and sometimes other factors force you to do it. It is true that two other countries had systems that were very similar to the Affordable Care Act, but we don't even have to look internationally. All we had to do, and the reason we had the Affordable Care Act is the model was here. We built the model in Massachusetts, and Governor Romney passed that law and helped construct the Affordable Care Act template in Massachusetts when he supported the legislation that was passed in that state in 2006. Now, he walked away. He denied accountability or authorship of that law when he ran for president last year. But the bottom line is that Romney Care is Obamacare. He would not own it. He pretended that they were totally different. And the fact is the differences are minuscule. So we had the model. It was put in place. And the reason both President Obama and Hillary Clinton in their presidential campaigns of 2008 ran on what became Obamacare was because Romney Care had just been enacted and appeared to be a template for the whole nation. And just to remind you further of our history lesson, Governor Schwarzenegger proposed Romney Care for California in January of 2007. So once it was enacted in Massachusetts, the idea spread like wildfire to first California and then to the presidential election of 2008.
So did Massachusetts template their system to resemble any particular, let's say, European system?
Well, I don't know all of the people who were involved in the Massachusetts plan, and I've read some histories of and accounts. It is not clear to me that that was modeled. My understanding of the evolution of the Massachusetts reform is that it grew out of ideas that were, first dating back to the mid-70s, outlined by Professor Alan Enthoven at Stanford. Alan Enthoven in the mid-1970s wrote several articles and published a book that said that the U.S. healthcare system needed to be reformed to provide a mechanism for the large number of uninsured and people who bought insurance on their own to pool their resources, to pool their purchasing power into what he called health insurance purchasing cooperatives. Those were health exchanges. Professor Enthoven did not develop this idea completely out of his own brilliance. He modeled his proposal on the Federal Employee Health Benefits Program, and he was quite open about it. It wasn't a secret. He wrote in the book and in his articles, he said, I am proposing a national reform that would take the ideas that have been tested and in operation for federal workers and make it available to everybody. Subsidies for people who were too poor to buy it on their own or didn't get help through work, and regulation of insurance products so that people were not ripped off in these markets. The ideas have been around for decades, and they originated in the United States. Just to illustrate the idea, with blues music in the 1950s, it originated in the United States, went to London and England, and came back to the United States as the British invasion. But the ideas and the music originated here. Well, it's similar to the intellectual foundations of Obamacare. all of this can really be traced back to Professor Enthoven's work in the 1970s.
I see. So, Jerry, it sounds like we're taking a first very gentle step here. And here's America. We like to pride ourselves in being a diverse culture where we do learn from many different sources. And that's been a strength of America over the years, that we have taken so many diverse pieces of information, of people, of cultures, of information, and we really put it together and extract hopefully what works best from all of these sources. And we do this. So here we are taking this first step. First of all, what would you recommend to the citizens of California right now to do now that the Affordable Care Act has begun as of October 1st, and I think we have till March of next year to enroll? And so what do you recommend that people do?
So my recommendation to Californians is, first of all, if you're insured today, if you receive your insurance through your place of employment, you probably are not eligible for benefits under the Affordable Care Act, and you will continue to get insurance through your place of employment. What you will have in the future is, if you change jobs, if for some reason you lose insurance through your place of employment, if you get sick, you will no longer be able to be denied insurance in the future. But for now, you will continue to get insurance the way that you do. You get it through your job. If you are on Medicare today, the Affordable Care Act really does not apply to you. You stay on Medicare and you have qualified insurance. You do not need to worry about the Affordable Care Act. So my message to Californians is, if you buy insurance today on your own without any help because you're self-employed, or you don't get insurance through your place of employment, go to the coveredca.com website and see if you qualify for a subsidy. You may qualify for a subsidy, and if you do, I guarantee you, if you qualify for a subsidy, your insurance will be less expensive next year. If you are uninsured today, please go to the coveredca.com website. You will either qualify for a subsidy to buy an insurance policy next year, or if your income is low enough, you will qualify for free coverage under the state's Medi-Cal program. But in any event, if you are uninsured today, you will almost certainly qualify for something next year, which will make insurance either free or highly affordable to you.
Okay, Jerry, and a final thing. You've outlined basically what Affordable Care Act is on its high points, and you've said what people can do here in California. Do you have any vision of where we go from here? Here's the United States, the only major developed country in the world without a national health care system, and the most costly per person among the advanced nations. But here we are taking a beginning step. Do you have any other foresight on where you think we're going from this very small first step?
Well, Zane, I wish that I could forecast accurately where we go from here, because frankly, I think that we're at a fork in the road. And so I see two very different paths. On one path, the opposition that we've been experiencing for the last 3.5 years, targeted against the Affordable Care Act, begins to subside. We move forward. Millions of Californians and millions of Americans are newly insured. But the program is still not working perfectly, but we find a way, in a bipartisan way, to fix what isn't working so well without gutting the program and without starting from scratch. And, I don't know what the probability of that is, but that's one path. I think the other path is that even if we move forward, that there continues to be high cost, dissatisfaction, despite the expansion, still millions of Americans who are still not insured, and perhaps a growing sentiment that the system is just too broken, and that even this valiant effort is not enough to change the course. And if that is the case, then I think we're talking about more fundamental changes in the system, starting from scratch. And I can see that either of those possibilities are possible. They're not remote, and I can see us going down either path.
Okay, Jerry, we're going to have to leave it at that. We've had quite an explanation during this show of economic solutions, and we're going to have to end the show at this point. But I want to thank you so much, Dr. Gerald Kominski of UCLA. I'm Leonard Zane. Thanks very much for watching.